Thanks to the organizers for inviting me to present about industry's response to COVID. And as indicated, I'm the head of cardiovascular, renal, and metabolism development at Novartis. So, as you've just heard, this hits particularly close to home to our group, where we're trying to develop new therapies to extend and improve patients' lives. Individuals who live with cardiovascular disease and try to prevent it. So I've segmented my talk into two distinct sets. The first is focused on the research and development efforts in pharma in collaboration with many other people, as we'll talk about, to develop new therapies for COVID and for the COVID-associated complications that you just heard about. And these come in a variety of flavors. Sponsored research, which means trials that the pharmaceutical company itself would sponsor and conduct in collaboration with academic investigators typically. Investigator-initiated trials, so those would be trials where we're approached by an investigator who's interested in using potentially one of the medicines that we have in our pharmacopoeia to test whether or not it can be useful in their patients. And then, of course, we've done this through multi-stakeholder collaborations, and I really want to give a shout out to the regulators who've really adapted, to this new situation, made it much more straightforward for us to get clinical trials done in patients. There have been recent guidances, as we'll talk about in a couple of minutes, that really help us overcome a lot of the challenges in conducting clinical research in an era of a pandemic. The second major category of the talk will be about what we're doing to ensure that we continue to develop innovative medicines and deliver those to patients. So you heard a little bit of that in the introduction from our co-chairs about how we can make sure that those individuals who need, cancer therapeutics or cardiovascular therapeutics or therapeutics for their rheumatoid arthritis or various other diseases, how we can continue to make sure that those medicines continue to be developed, again, with all of the challenges that come along with conducting clinical research in an era of a pandemic. And I think what you'll see is that we've I think, as an industry, actually a wider industry, as a healthcare industry in general, been incredibly effective at adapting to these limitations on conducting our studies. And in many ways, certainly within Novartis, and I imagine in many other companies as well, we've adopted new ways of working. So we're experiencing that right now through Zoom, through our virtual kind of interactions. But even beyond that, there are ways in which we interact with our advisors and potentially with regulators and with the payers to ensure that the medicines can continue to get to patients who need them. So let's talk about the first category first. So when you think about the potential responses to a COVID pandemic or any public health emergency, there are a variety of things that we do in industry. So the first is we can provide resources. And so in the COVID era, we've provided funds, donated product, as you can see there, to facilitate getting new medicines to patients or having them be able to access needed additional resources to take care of their patients themselves. We have entered into external collaborations, mostly around research and discovery, so understanding the virus better. As you heard about, there's a lot still to learn about COVID-19. And there are a lot of ways in which we can partner with foundations, as are listed here, or academic groups, in order to advance the science and better understand how we can attack the virus and fight back. We have a lot of internal discovery approaches. So in addition to the external collaborations, we have internal work where we look at our medicines and try to evaluate whether or not the mechanism of those medicines could play a role in fighting the disease or some of its complications. As you can see, some of these are directed towards discovery of new molecules or new approaches to treating the medicine. Some of them are figuring out ways to maybe leverage some of our older medicines to try to see if they would be effective as well. And then, of course, there are clinical investigations that I just touched on, either sponsor-studied studies, investigator-initiated trials, or managed access requests, so requests to try a medicine for a particularly ill individual. Those have also been facilitated through our systems. So getting a little bit more granular on a few of the things that we're doing with respect to developing new therapies, we have 3 studies that we sponsored very quickly. I think one of the most remarkable things to me, having been in the pharmaceutical industry for about 15 years, is how quickly a large organization could adapt to the urgent need for new research and getting patients access to these potential therapeutics. So we have 3 sponsored trials that were started. One looking at canakinumab, an IL-1 beta inhibitor to, as you just heard about, treat potential treatment for cytokine storm. Ruxolitinib, similarly for cytokine storm, and then hydroxychloroquine. We started a well-controlled study to evaluate its antiviral and immunomodulatory effects. The other approaches were coming from the academic community, interest in testing a variety of medicines in about 32 investigator-initiated trials. These were supported, for example, with medications like secukinumab, imatinib, valsartan, as we heard about, to test whether or not RAS inhibition and angiotensin receptor blockade would be beneficial in these patients, and omalizumab for its antiviral effects. And then we have a series of access initiatives. So developing the medicines is important for sure, and demonstrating that they could be effective, for the disease is of course quite important. Then you've got to make sure that you can get the medicine to patients as well. And so as you can see, there's been a variety of efforts there to ensure that these potential therapeutics could get to patients if they were actually shown to be effective. So those are kind of writ large what Novartis has been doing with respect to addressing the COVID pandemic. And as I said, I think other pharmaceutical companies are taking a similar approach. With respect to the development of non-COVID therapeutics and non-COVID clinical trials, there are a series of important limitations that we had. So there are a couple of imperatives, right? So centers in affected areas have to focus on delivering care to COVID patients rather than necessarily conducting clinical trials in non-COVID indications. And unnecessary exposure to the virus should be avoided in order to slow viral spread and really flatten the curve. The consequences of these 2 imperatives are that centers typically would restrict access to those who are in need of care. So individuals who had COVID, of course, would be able to come into the hospital, or people with serious illness would be able to come into the hospital, but clinical research associates or people who are going to the center to just participate in the study, unfortunately, would not be able to attend. Similarly, local regulations would limit excursions from home by participants and clinical research associates, so we couldn't really get into the centers. And then some people just may be afraid of leaving their home to travel to a center for research purposes, especially individuals in high-risk groups. So you can imagine, as being the head of cardiovascular renal metabolism, that's exactly the patients that we typically try to enroll and get into our clinical trials. The interesting thing, though, is that we adapted very effectively to this as well. We have about over 300 trials in various stages. The first 2 parts of in planning and recruitment is about 50% of our trials. And in these areas, we did see slowdowns, both in terms of study initiation, in terms of recruitment, because of those 2 things that I just mentioned on the previous slide, right? Physicians and practitioners were focused on delivering care to critically ill patients. And of course, patients weren't able to come in to participate in clinical studies as easily. The way we adapted to this was by actually delivering medication directly to patients in some cases, using home nursing visits, remote medical monitoring, and using virtual safety assessment. So we adapted our practices in collaboration with health authorities and regulators and the academic community to be able to continue to conduct our clinical research studies to the extent that most of the impacts were quite manageable. So I think if you think about specifically cardiovascular care and cardiovascular clinical research, there's one really important point that I think we all recognize, which is that cardiovascular admissions have declined substantially during the pandemic. So I put a couple of resources here that show you that even for ST segment elevation MI, heart failure exacerbations, those admissions are down about 40%. So, is that because they don't exist in the community anymore? Is it because patients are afraid of coming into the hospital and exposing themselves? Or is it because, the environment has completely changed and everybody's leading a stress-free life and there aren't as many of those events happening? We don't really know. But what ends up happening, the impact on clinical research, is that most of our clinical trials and our clinical endpoints are geared to measuring those effects. So individuals, when they come into the hospital, if they're in a clinical trial, we're usually measuring admission or cardiovascular death. And if those things are down, it affects some of the assumptions that we put into the design of our trials. So we've had to work with our executive committee leadership to adapt in ways of evaluating our clinical research studies and making sure that we take these things into consideration when we're planning our analyses in the future. And again, there's been a lot of support from regulators on this as well, recognizing this unprecedented situation. So in summary, the healthcare ecosystem has really responded with great agility to address the pandemic. R&D of new treatments for COVID-related illnesses, as you saw, are moving forward. And in non-COVID diseases, we've really adapted our clinical research ecosystem to the new environment. And a lot of these changes that have happened over these last few months are here to stay. So some of these efficiencies and patient centricity, I think, are things that are going to be really favorable for patients in conducting clinical research in the future. Thanks a lot.
Thanks, David. That was fantastic, and gave, I think, a fantastic overview on the position of pharma, who actually played a pivotal role in this whole pandemic so far. You mentioned your current research areas, and there's a question which probably is on many minds. So I think that's probably speaking for a lot of people. Is how do you interpret the hydroxychloroquine data collected so far?
Yeah, well, I mean, I read the same things that you all do, so I'd ask the rest of the panel members as well. I mean, it seems to me that there's good theoretical reason to believe why hydroxychloroquine could be a beneficial therapeutic. There were earlier studies, I think, in the earlier SARS outbreak, where there was some evidence that maybe it would be beneficial. There was a small study in France, I believe, that showed that there could be utility of hydroxychloroquine. Our position was there's potential utility for hydroxychloroquine, but it needs to be studied in a well-controlled, properly powered, randomized controlled clinical trial. And that's exactly why we initiated the study at the beginning of the pandemic. So, the way I interpret it right now is that it appears that the QT prolongation or potential arrhythmic effects of the drug may not be counterbalanced with enough efficacy to merit use. That's my interpretation of what's been written.
Thanks. And another question, which I think is also very interesting, might be a little provocative at the ESC to ask, but you as cardiorenal metabolic, is that a cardiovascular disease? Is it a pulmonary disease? Is it a vascular disease? What kind of disease are we targeting? I'm happy to share this with the panel if anybody has an idea. But where do you place it?
You're talking about COVID-19?
COVID-19, yeah.
Well, I think we heard it's a systemic disease. I mean, it's a and it affects aspects of cardiovascular health, pulmonary health. I think it depends, and I don't think we understand the risk factors. I'll throw it to the panel if they have more insights on this, but I'm not sure we understand exactly what leads one patient to have more predominant symptoms than another. But maybe Dr. Lewis could comment on that.
Yeah, no, I think that's the $1 million question, why some people get sick and recover, some people never get symptoms, and other people get deathly ill, besides the things that we've identified. suppressed immune system, an inflammatory state to begin with, the diabetes. But other things like being hypertensive, that doesn't suppress the immune system. Why are these patients at increased risk? I think there's a lot we don't know.
There was one question which I thought is quite interesting, because I think going back to what we've all read, I'm not sure if one of you has the answer, David, Dr. Lewis, there seems to be a higher rate of healthcare professionals affected of the disease. Does anybody has an idea of why this is the case?
I think early on, it really was a question of viral load and exposure. Okay. The cases that were quite shocking where it was previously healthy people seemed to be ones who were close up in an aerosol generating procedure, either didn't know the patient had it, didn't have adequate PPE, rushed in to put someone's mask back on when the mask had fallen off and didn't have time to put their own PPE on before going in the room. So very often it was an exposure situation.
Okay.
By the time it got to Boston and we were fortunate enough to have adequate PPE, we have had zero so far employees infected with COVID in the workplace setting. People have gotten it, of course, from other reasons. But I think if people have adequate protection and adequate knowledge, we can protect our healthcare workers against this.
And then another question back to David. Thank you very much. Sorry. Another question back to David, because you mentioned there was a lot of lessons learned from how we do patient-centric work, etc. But there was also a lot of collaboration now within the industry. Is that something we can bring forward going forward post-COVID? Is that something we can take?
I hope so. I mean, yeah, and I would expect so. I mean, I think in many ways we've learned different ways to work with each other, especially in in emergent situations. I think we all have to rise up and and fight the battle in the best way that we can in those types of situations. And I think we as appropriate, we knock down all the barriers to make it happen. And whether that's with industry or it's with the regulators or it's with the academic community, I think, we were successful kind of broadly with that. And so I think in the future, for sure, it allows us to mobilize more effectively.